Yes.
It is taking some time. Shashi, can you check it on our YouTube channel whether it's live or not?
The Zoom said we are live, but I'm not able to find it in the YouTube.
Okay. There might be some network issue, I guess.
Yeah, I'm not able to see YouTube.
Yeah, it is live on my screen, but very slow. Yes, in a seconds. It's working.
Is it showing something?
Yes. Hi. Good evening, everyone.
Good evening.
Hi. Hi, good evening, everyone. This is Dr. Rajat Jangid from Indian Cartilage Society, and I welcome you all for the first webinar on cartilage about the cartilage science. And we have started this initiative to propagate cartilage science in India and globally. And the purpose of this webinar, we have senior faculty guys who are going to give their presentation, their knowledge, share their knowledge with us, and we have young guys as well presenting their cases so that we can discuss about cartilage science. So to moderate this session, I hand over to Dr. Sachindar.
Thank you, Dr. Rajat. Welcome everyone to the Indian Cartilage Society webinar. So, just to give you an introduction about our initiative, the Indian Cartilage Society will be coming up with webinars every month in the second Saturday at 7 p.m. IST. And the initiative is directed primarily at young orthopedic surgeons who want to learn cartilage surgery or who want to understand it better. We will be having faculty experienced arthroscopy and cartilage surgeons from India and around the world talking to us and discussing with us about cartilage science and cartilage surgery. We have invited a lot of key opinion leaders for this program, and we'll be having wonderful program in addition to scientists talking about cartilage science. So welcome everyone. In today's program, we have Dr. Divya Prakash, who will be talking about the biomechanics and the anatomy of cartilage in the presence of a meniscal root tear. Unfortunately, we don't have Dr. Nishit Shah with us today due to some personal reasons. Following Dr. Divya Prakash talk is Dr. Soumya Agarwal, who will be talking about his experience of microfracture drilling for osteochondral lesion of the knee. Now, I hand over to Dr. Rajat to introduce Dr. Divya Prakash. Thank you.
Welcome, Dr. Divya Prakash, to this ICS webinar. So, Dr. Divya Prakash is presently is senior consultant at Sandwell General Hospital, Birmingham, UK, and he has done his MBBS from Patna Medical College and his MS Orthopedics from Rajendra Medical College, Ranchi, India, and he has done his FRCS MCH in UK. And I would request him to introduce himself about his practice in UK, how he takes up with the cartilage and cartilage patients. Dr. Divya
Hi,
Prakash.
Rajat. Yeah, hi, Rajat. Thank you very much for the introduction and Sasinder and the Indian Cartilage Society. Thank you for having me over here. You've opened a can of worms over here. Um, to answer your question, I'll actually take you back to a little bit of my earlier days. When I became a consultant, I was with the British Army and I was treating soldiers over there, and many of them were fit, young, active, and they would come to me with injured knees. The other thing was that initially I was a consultant in a place called Portsmouth, and Portsmouth is a seaside city in south of England, and they used to have a concrete track around the beach, and all the youngsters used to run for miles and miles on that, and they used to come to me with a problem, and I started to have increasing interest in people who were young and who are having troubles with the knees, and that's where my interest came from. And when I moved to Birmingham a few years later, I continued to grow my interest. So my entire emphasis is joint preservation. It is not just sports injury, it's not just cartilage regeneration, but overall it is joint preservation. So even when it comes to doing joint replacement surgery, I would much rather do uni-compartment replacement rather than a total knee replacement. And um, I've got a very high volume practice for joint replacement surgery as well. I introduced cartilage regenerative procedures techniques to my hospital, including AMIC, which I'm sure you guys are familiar with. And here I am. Here I am. And um, I have I have continued to teach other people regarding joint preservation. I started the Midland Knee Society in 2018. And it is a very flourishing society. And we have that forum where people bring all their complex cases to discuss. So if you guys are ever over here in UK, let me know. And if you can arrange a time and you come for one of the meetings, you'll really love it, because over there, people bear themselves. They say that, look, I've got this problem patient. I don't know what to do. Can somebody come up with some ideas? And you got 40, 50 senior people over there racking their brains, trying to solve the problem. And it is lovely. So if you guys come, you'll enjoy it. And that's about me. Sorry, if you want
Doctor,
to know a little bit more about me, I gradually got inducted into deeper and deeper into the niche societies. And have you guys heard of an organization called BASC? BASC is the British
not yet.
Association for Surgery of the Knee, and that's the apex body that gives advice on all the different aspects. So I've been their executive. There are only 12 executives. I've been one of the executives until 2 months ago, and I was with them for about 6 years. So that's part of my journey as well. Thank you.
Hi, Sashi.
That's
Uh,
fantastic, sir. And
yeah.
we are lucky to have you here. And I would request, what is your message to the young cartilage surgeon who are about to start their cartilage journey and just want to start with the cartilage or the regenerative procedures?
No, sorry, can you ask me that question again? I didn't understand it clearly.
Okay, what is your message to the young cartilage surgeons who are about to start their journey? That means they want to start the joint preservation surgeries. What is your
Okay.
message?
My advice I'll give an analogy. In fact, I will give two analogies which I give to my patients. And I tell them that if they've got cataract in one eye, will they have both the eyes operated? No, they will not. Because what nature has given us is far superior to what any human being can create. So if you're able to preserve what nature has given us, then that is the way forward, and your patients will thank you for the rest of their lives. The other thing is that you got to remember that it is all very well that if you've got a 75-year-old patient with completely arthritic knees, you're going to do nothing else other than a total knee replacement. But your challenge, your enthusiasm will come for a younger patient who's in his 40s and 50s, who's keen to do sports, who's keen to run around and do his activities. He will be grateful if you can keep him going rather than recommend any total knee replacement or any kind of knee replacement surgery. The other thing to also remember is that these young patients who are coming to you with their earlier problems, they are very keen to get better. So they will follow your advice, they will listen to you, they'll do the exercises, they'll do the do's, and they'll not do the don'ts. So they are patients who are more compliant, at least in my practice, and it is a pleasure to work with them. So save what you can. There's nothing better than that. And this is an evolving science. We are talking about regenerative cells, but we are also talking about stem cells, which are potentially coming in. It all takes time. You are young maybe at the moment, but in about 15 years' time, 10 years' time, things would have evolved and you'll be in a much better position to use it. So it is a very exciting field.
So I think the message is very clear from you that preserve the joint whenever possible. So with that, I would request you to today's you to start your today's presentation, sir.
Thank you very much, Rajat. I'll start sharing. Can you see my screen?
Yes, perfect.
Yes, sir.
And I'll see if I can do a, can you see my screen still?
Yeah, it is in slide share.
Okay.
Slideshow. Yep.
Okay. Hi, everybody. I was given the topic of talking to you regarding implications of meniscal root tears. Now, before I start onto the journey of the implications, we've got to know a little bit about the meniscus itself. I don't have to give you the anatomy of the proximal tibia inside the knee joint. I'm sure that all of you are completely familiar with this. The one thing I will say is that this was a picture taken from the internet, and this was published about 15 years ago. And the one thing that is conspicuous by absence is that there is no mention of the meniscal roots over here. Can you see? They have marked out everything. They have given the distances, but they have not talked about the meniscal root. So where is the meniscal root? I mean, this is the anatomy of the right knee. The anterior ones are there right in front, but the anterior ones are not as important as the posterior ones. Now, the posterior medial one is sitting just behind the ACL, and the posterolateral one is again sitting just behind the ACL attachment. Now, because of the location, you can see that it's going to be very difficult to see them unless you really want to have a look. Okay, so what is the incidence of meniscal lesion? We all know that it is very high, and all of us come across that, whether it's a young person or an old person. I'm not going to be going to the statistics of it, but the meniscus is an important structure. So what exactly is it? It's a crescentic kind of a cartilage, and it has got fibers running in all directions. It has got the circumferential fibers that run along the entire crescent. It has got the radial fibers that crisscross that. But more importantly, there is also a big meshwork. So it is not a solid structure. It is not as if it is a piece of wood. It is something that is spongy. And the nature is such that it actually holds water inside it. And why does it hold water? Because it has got hydraulic permeability. It can suck water inside it. So it is not completely dry. Don't get fooled by that. And when there are compressive forces, it actually acts as a shock absorber. And that is the essential part of it. So again, I don't want to go into the chemical side of things. But the important one is that the hydrophilic molecules in the meniscus, they actually suck water inside. So it has got the potential of keeping itself wet, moist, and functional. So what is the essence of meniscus? In the knee joint, if you see the top of the tibia, for all practical purposes, is like a flat surface. And on top of that, you got a ball-shaped structure, which is the femoral condyle that's sitting over there. Now, if you imagine a ball sitting on a flat surface, the ball is going to roll, isn't it? So what the meniscus does is it is like this little ring that I have shown at the top right of the screen, which allows the ball to sit in it. So the area of congruity increases, but also it increases the stability. And if you look at the picture below that, it's a ball on a flat surface. It is point loading at its point of contact, and it has got the potential to roll. So it is an unstable structure, unstable configuration, unless there is some kind of a constraint in it. And this is a meniscus that provides the constraint. Now, again, why are we talking about the meniscal root? Traditionally, if you look at the picture on the right side, then when people were teaching us, when I was a young doctor, junior consultant, or even a junior registrar, we were being taught about different kinds of meniscal tears. But you can see from here that there is no mention of the meniscal root. Now, meniscal root was first pointed out by Pagnani in 1991, and that's only about 35 years ago, or 33 years ago. Before that, there was no mention of the meniscal root. And once he'd done that, initially there was very strong resistance to accepting it as a pathology. And lots of people used to think that it was actually an industry-driven condition which the industry wanted to promote its kit for doctors to repair. But more and more people over the years have found that no, it is actually a genuine problem. What does the meniscal root do? As you can imagine, the root holds something, a plant, a tree, in its place in the ground. Now, if it is a structure that is like an arch and it has got two roots, the whole structure will be kept anchored into the ground or into the flat surface by the roots. So what is the implication of having an intact meniscal root? It is staying in place, and if it wasn't there, if the root was broken or cut, then the whole thing would slip outwards. So extrusion, I've just mentioned that the meniscus gets pushed out. What does meniscal extrusion mean? What is the definition? The definition is that any movement of the meniscus medially or laterally away from the edge of the tibia by more than 3 millimeters is extrusion. Okay, this is important to note, especially for the young doctors. The whole meniscus does not have to sit outside. Only 3 millimeters. The moment it touches the 3 millimeter barrier, and if it's moving to the side, that is meniscal extrusion. And why is this meniscal extrusion important? Because the congruence between the femur and the tibia will decrease. Okay, and what does that mean? That implication of that is that the pressure that is being transmitted from the femur to the tibia dramatically increases. And there are studies that have shown that the load increase is equivalent to a complete meniscectomy. Now, about 40, 50 years ago, everybody used to do an open meniscectomy. There used to be a Smiley's knife, and there used to be mini open, and they used to take out the entire meniscus if there was a meniscal tear. 20 years later, they found that it was a very bad operation. Initially, they thought that it was a very good operation. When I first came to UK, I remember one of the surgeons, he said he did an operation, excision of the meniscus in about 15, 20 minutes. And he, was boasting to the theater staff that, it's a neat operation, neatly done. Great. At that time, I was a junior doctor. I was not even a registrar at that point. And I was very impressed. I said, he took out the entire meniscus. And obviously, now we know that doing an entire meniscectomy is not a good idea. And that is the effect that a meniscal root tear has. It is like if the meniscal root is not repaired, it is like excising the entire meniscus. The way I also explain it is, think of the meniscus like a swing. It has got two anchors at the top, one on each side. Because they are attached at the top, the whole swing is functional, okay? And if one of the anchors breaks, what happens to the swing? It's no longer a swing. It's not functional. And that's exactly what happens to the meniscus. So the meniscal roots being intact is critical to the function. So I started reading more and more papers, and I thought that I'd give some references that you guys should also look at. In 2020, this was a very large multicentric study of, I think, 4 countries, and there were more than 8 centers. This included Sweden, Germany, USA, Brazil, and there were more than 8 centers. And they found that if the meniscal root's torn and there is extrusion, the knee is associated with accelerated arthritis. Okay, so if there is no arthritis, the knee becomes arthritic. If it is already arthritic, then the arthritis is accelerated. There was another paper from 2023, and this also showed that association of the medial meniscal root tears and non-root tears with worsening radiograph. This was a radiological study, and they found that there was statistically significant difference. In the non-root tears, they did not have accelerated arthritis, but in the meniscal root tears, the arthritis was accelerated. So I would recommend, I've got references at the end, which you guys can look at. So what is the definition of a root tear? We've talked about what is an extrusion. What is a root tear? The root tear basically means that there has got to be a complete radial tear within 1 centimeter of the meniscal attachment into the bone. Okay, 1 centimeter or 9 millimeters, whatever we say. At that point, 1 millimeter is not going to make that much of a difference. I at least cannot make the difference of 1 millimeter. So if it looks like a 1 centimeter and there is a complete tear of the meniscus, for me, that is a meniscal root tear. The second definition is that if there is no root, the meniscus is intact, there is no tear in the meniscus, but if the soft tissue is avulsed from the bone. And the third one is that a piece of bone is also avulsed. So all these 3 comprise and form the meniscal root tear. So just to give you a couple of images, that you can see it's not an avulsion, it is a complete tear of the meniscus very close to the root. And that actually is a meniscal root tear for all practical purposes. This other one is also a very similar one. The attachment to the bone is intact, but there is complete tear of the meniscus. Okay. The other reason why I put up this picture was because unless you specifically go looking for that, and it's so close behind the ligaments that you'll miss it unless you look for it, or unless you've had some reason to suspect it on an MRI scan. And on MRI scans, you can see this white, bright zone where close to its attachment to the bone. This, if you see something like this, take it as a meniscal root tear. Okay, similar over there. Now, there are different types of meniscal root tears. Okay, type 1 is that it is only a partial tear. it is not a complete tear, it is a partial tear. I mean, if I go back to this picture, this is a complete tear of the meniscus, but this is a partial tear. Okay, but this will comprise as a meniscal root tear. So if there is a partial tear of the meniscus within the 9 millimeters, the 10 millimeters from its bony attachment, then it is type 1 of meniscal root tear. And it was classified by Laprade. The percentage is about 7% or less than 10%. This is the big one. The complete radial tear of the meniscus within 9 millimeters or 10 millimeters of the bony root. That is the main one. And again, I'll go back to the picture. This is the most common one. 68% of the patients are this. All the others types, I mean, there are 5 types. All the other types are less than 10%. Okay. So this is type 2, which is the main one, is a complete tear of the meniscus within 1 centimeter, and it's 68%. Now, the third type 3 is complete root detachment, but with ipsilateral bucket handle tear, again low percent, so it is associated with bucket handle tear. The fourth one is oblique tear with complete root detachment. So the difference between type 3 is that type 3 has got bucket handle tear associated. This one doesn't. It's just a complete oblique root tear from the bony attachment. And the fifth type is bony avulsion. So a piece of bone is also avulsed. And this is also less than 10%. So if you go back to it, then this is the most common one on almost 70% of the cases. The other thing that we have found through research and other things is SONC is something that we often talk about in the knees. SONC is associated in up to 80% of meniscal root tears, 80%. And you can see evidence of SONC over here. SONC doesn't mean only the femoral condyle, it is also the tibial plateau. Okay, you can see evidence of meniscal root tear over there at the back, and this is SONC. And also, in 28% of the patients with degenerative meniscal root tears, they ended up with having total knee replacement in less than 3.5 years. So having a root tear has got significant implication on the cartilage longevity or nutrition of the knee joint. Now, this is another multicentric study where the posterior, sorry, let me just move this away. The posterior medial meniscal root tears, they found that it was associated with worsening medial tibiofemoral damage. And again, this was a very large study, and it showed that the isolated medial posterior root tear is associated with progressive arthritis. So there are lots of studies that actually talk about that. Now, basically, there are 2 different types of meniscal root tears. One is traumatic, the other is degenerative. The traumatic, as you can imagine, is in younger people. The lateral side, incidentally, is more than the medial, and it is only in about 30% of the cases, okay? Whereas the degenerative one is about 70% of the cases. They are chronic, low energy, and the medial is more than the lateral. I'll not go into the repairs because somebody else will be talking about it. So the conclusion is that if there is a meniscal tear, the meniscus becomes unfunctional. And it is the same as having a total meniscectomy. And you're not going to let, especially a young person, young fit person, have a total meniscectomy done. Likewise, if you can identify a meniscal root tear, it is your duty as an orthopedic surgeon, as a knee specialist, especially if you are youngsters learning their trade now, you've got to do the meniscal root repairs, but that is a completely separate topic. The joint congruence is lost, and there is point loading, which I mentioned earlier, and there is accelerated degeneration. Now, just to summarize this, if you see that the tears are starting over there, it is still stable in the picture B. In picture C, the meniscus is getting extruded. And what is the end result? With the extruded meniscus, you'll see that the arthritis is set in. Okay, and this is a reality of life. Just to finish off by showing a few pictures of my own patients, there's meniscal root tear over there, there's extrusion you can see in the front, and you can see the osteophyte. You know, all the things that I've been talking about. Again, AP view, the meniscus is not completely out, but it is out by more than 3 millimeters. You can see the osteophytes over here beginning to form, and osteophyte forming over there. In this one, again, the meniscus is extruded. And just remember, the extrusion has got to be above the tibial plateau. It has got nothing to do with the femur. The extrusion, the definition is that it has got to be more than 3 millimeters beyond the tibial plateau. And you can see edema in the medial tibial plateau. Okay, so if the meniscus is not functional, it's not going to work. Thank you.
Dr. Divya Prakash, I think it was a very interesting presentation, and this is exactly the purpose of the ICS webinars. We want to understand the basics of why cartilage is important, why the meniscus is important, and how they function. So it was a very interesting presentation. I love the analogy of the swing, where both the chains are attached and the swing can function well, and the seat of the swing being far away from the attachment, exactly like the meniscus. And when one of them is gone, the whole structure is gone. That's a wonderful analogy. And I used to tell most of my students, like, you you can never replace evolution. I mean, people can believe or not believe in a lot of things, but we can never not believe in evolution, and that is millions of years old, and man can never replace it. We are still learning, we are still trying to replace it. And meniscus is n- not something that can be just given up. So yes, possibly it was the best treatment to do a complete excision of the meniscus at one point of time, but fortunately we are learning better and better, and there are a lot of treatment options to first to understand what it does and to preserve it as much as possible. Thank you for this wonderful presentation. Do we have any questions from the panel here? Dr. Navaledi.
Dr. Divya Prakash, good evening. This is Dr. Navaledi Shankar, Secretary, Indian Cartilage Society. I was really happy, and my president of Indian Cartilage Society also is there, and our educational chairs all are there. They're really happy when you told that a lot of things happening in UK, and definitely we'll be very happy to take part in Europe, because in Indian Cartilage Society, a lot of work has been done, and I think Dr. Rajat can also take part in initiating our presence in the UK. That's the first thing I want to tell you. Thanks for the invite. Second, we have seen like lot of young patient with medial extrusion. Do you see also there young patients? It's not about traumatic. It may be non-traumatic also. Young patient, it is very difficult for us to tell that there's an extrusion. They're not able to. They think that the MRI report says extrusion, so they treat it, okay, it's a normal meniscus, only extrusion. So how do you deal the type of patient?
The way I see it is that if I have got a patient sitting across the table from me in the consulting room, he will not be there to have a chit chat with me and have a coffee. He's there because he has got a problem. If he has got a problem, then it is where I come in as an expert. I've got to find out what the problem is. Now, the radiologists quite often give an opinion, and I have to override what they are saying, because I love the reports that come from them, and they are very experienced. And for me, it is important that they give an opinion, because many times I miss something which they point out. But the advantage that I have over them is that they are looking at only the nitty-gritty of the images, whereas I'm examining the patient. Now, if the patient is sitting in front of me with a patellofemoral problem, with a maltracking patella, And if somebody is talking about meniscal extrusion, that is not going to be important. So the clinical correlation is very important. If the radiologist has said that there is extrusion, then please have a look at both the posterior as well as the anterior roots of the meniscus. Usually it is the medial. Have a look at that. And if by any chance, for whatever reason, if you're doing an arthroscopy, then put a probe into the posterior part, have a look, see what's happening to it, whether it is anchored or not. Because believe me, it is very easy to actually miss a posterior root tear. And nobody even talks about the anterior roots, and that is less important, but definitely important. Many times I've seen, I'm sure you people must have also seen, that the meniscus is sitting in front of the tibial plateau. The medial meniscus anterior horn is sitting in front of the tibial plateau, whereas on the medial side, on the inside where the weight loading is there, it is sitting perfectly normally. So there's got to be a lot to be said about where the problem is and how you have identified it. Sorry.
Dr. Divya, sorry to interrupt you. Your eye sees what your brain knows. So if we see our knowledge regarding the meniscus root tears, previously when I used to operate the patient for ACL surgery or any other knee arthroscopy, I used to see the ACL, the cartilage, the meniscus, but not the roots. So if I see my practice since last 5 years or so, the incidence of the meniscus root tear in my arthroscopy has increased drastically.
Absolutely.
So our knowledge have changed our practice as well. So do you see that in your practice as well? And also, what are the clinical features? What are the basic radiological things those you should do in your patients and in your MRI that suggest you that there is a meniscus tear and you need to do something?
Very good question over there, Rajat. First of all, the history, the mechanism of the problem. Okay, that will give me a clue. If it is a 65-year-old person who's not very mobile, the kind of damage or the treatment even is going to be completely different. But if it's a 35-year-old who's sitting in front of you in your chamber, then you've got to have warning bells ringing, because younger people do not come to a doctor unless it is absolutely essential. Now, you're absolutely right that the eyes and the mind have got to work together. So now that we are increasingly aware of the meniscal root problems, we have got to specifically look for them. If you see there is a high signal of any nature in the posterior part of the meniscus, think that that is a possibility. Because even in the MRI images, one of the MRI images I showed you with the arrow pointing, I showed you that there was blurring of that. But it didn't look like a complete tear. It didn't look as if the root had come off. It just looked abnormal. It just looks abnormal. So as long as you know that you've got a suspicion that there is something that could possibly be happening over there, keep an eye. And if you are able to catch it even before the extrusion, even better. And in history, I mean, if there is a history of trauma, then whether there was effusion, whether there was hemarthrosis, what was the mechanism? Was it playing football? There was a nasty tackle. What happened? I mean, all these will give you a clue. So yes, I agree that in the past, about 10 years ago, I wasn't bothered about meniscal roots, but now I'm very bothered about it.
So in an aged patient, I think the typical history of feeling a clunk in the knee, I think that has to be there. And radiologically, if you see the shiny corner signs, that is the posteromedial, posterolateral, subchondral bone edema, that is quite suggestive that there might be a root tear or an impending root tear that you need to repair. So these are few things that we need to, we need to look in our patients as well, so that we can find the meniscus root tears.
But for elderly patients, you've got to correlate with the existing arthritis. If the arthritis is already there, then the chances of you being able to save the patient's knee with meniscal root repair is probably not going to be that high. and it will
So
be
what is
better.
your take? When do you need to operate these patients? What is your protocol? The alignment, the instability, the root tears. How do you rate them? Which is the first one to do?
If there is a root tear, unless there is significant bony malalignment, I would just go for the root repair. For the simple reason that the patient would not have come to you in the first place unless there was a root tear. The alignment can be adjusted later. The root has got to be repaired first. And if you, for example, if you do a tibial osteotomy and correct the alignment, and if you don't repair the root, you have not done the job, haven't you? Whereas if you have not done an osteotomy, but repaired the root, you have given yourself time, 5 years, 10 years, in which you can do an osteotomy if required. But you cannot lose the
So
chance
if
of good.
But this
so
is in
even
the absence of an actual deformity, right?
Sorry, say that again.
This is in the this scenario is in the absence of an actual varus deformity.
Yeah, if there is no varus deformity, then you don't have to worry about anything anyway. I mean, it's the cartilage pathology that you need to address. And yeah, I mean, I'm in agreement with you, Sasinder, that let's not complicate this too much because we are trying to teach our junior doctors. So let's stick to the pathology that they need to understand and address and to identify and then learn the techniques of how to address it. And of
Sir,
course,
one question. So, sorry. Sir,
Yep,
one question.
go ahead.
I agree that every root tear should be properly treated and managed operatively. But sir, do you think that all the patients who are operated, uh, do they do well? Do you think 100% of the patients do well, or we have to tell the patients in advance that okay, you'll be relieved up to 70% or 80%? Because so I think even if we operate root tears, but the patient is not 100% happy all the times. There is some sort of pain, or he is in some sort of pain all the time. So what is your take on that?
okay, very good question again. Now, if you saw the type 2 of the root tear was the commonest, which is about 70%.
Yes.
And that root tear is actually a radial tear of the meniscus. How are you going to repair that? It is going to be meniscal repair, isn't it? It's going to be meniscal repair with
Yes.
side-to-side sutures, okay? And you might augment it with a bit of bone blood clot. It is not
So
something.
for that we can so for that also, if it's a radial tear, we can drill a tibial tunnel and we can repair it like what we do as a root repair in between, and then we can take two bites on both the side of the meniscus and we can repair it. The radial tear also we can repair it like we do a root repair.
You can do. You can do. But it all depends on the
Yes.
type of care, the age of the patient, the mobility, and everything else. Sorry, I completely forgot. There was something else you were going to say. Yes, what you asked me was whether it's going to be 100% successful. Nothing in the
Yes.
world is 100%. Nothing. Um, what I tell my patients is that we try our best, but we cannot guarantee them. And the analogy, talking about analogies, I talk to my patient in analogies so that they understand. I said, suppose when I'm talking to them about the risks of the surgery, which is very important in consents in the Western world in particular. And they get worried, oh, I can get a blood clot in the leg, the clot can go into my lungs. We're talking to them about DVT and P and all that. I said, look, nothing in the world is 100% safe. I said, can you guarantee that you can go home and without having an accident? Can you come down a flight of stairs? Can you guarantee that you'll not fall down? And the worst one that I actually say is that even eating food has got risks. You can choke and you can die while you're eating food. So I give them the situation that they understand. So you tell them that you're going to do your best. And after that, especially when it is biological treatment, I tell the patients, once I have done my job, the patients can't control it and I can't control it because it is now left to nature whether you repair will heal or not. And that is true. You can do the best job there is, but it is the patient's biology that comes into picture. And I bring the patient into it as well. I said, I can't control it, but at the same time, I tell them that you can't control it. So they don't think that it is only my responsibility. Okay. So you
Okay,
got to take the patient into your confidence and explain to them in the language that they understand.
right. Yes, sir.
Thank you, Dr. Divya. Just an additional question. How much percentage of your root repair patients require centralization? And, or in other words, how many of your patients have an extrusion already, and how many of them you will want to do a centralization to correct the extrusion?
When you pull the meniscus back, it automatically centralizes it. So that is important. So once I've done the root repair and I'm satisfied, I actually don't worry too much about trying to pull it an extra bit or not. Because, I mean, you can overdo things, you can try and tighten too much that can have a further adverse effect. So I don't look at those things. I just make sure that there is enough secure attachment, and that will do the job.
Yep. Okay. And any suggestions on the post-operative rehabilitation for your patients with meniscus root repair?
It all depends on the type of repair that you've done. If you've done a bony procedure and if you've had to create a crater, then I would protect them for at least 6 weeks. I would not keep them in splint for 3 weeks so that the posterior condyle of the femur is not putting pressure on the back of the knee. So for 3 weeks, I put them in a splint in full extension. After that, gradual increasing flexion. At 6 weeks, I allow full flexion. And I allow only touch weight bearing, not non-weight bearing, touch weight bearing for the first 6 weeks post-op.
Yep. Thank you so much, Dr. Divya Prakash.
Thank you.
Dr. Rajat, do you have any further question, Dr. Navladi?
So, Dr. Divya, you told that you will, do the meniscus root repair, but as far as the ISACOS guidelines are there, you need to correct the alignment first, then comes the instability, then meniscus repair, and the cartilage remains the fourth. So, in any of your cases, have you done the simultaneous surgery of alignment correction or the cartilage procedure?
I do them separately.
Yep.
I do them.
So you do it separately. That means the high tibial osteotomy and or other osteotomy or a meniscus root repair. You do it as staged procedure.
Yes, I do that as staged.
Yeah.
Okay.
I would
So any
like
cartilage procedure
make,
have you combined it with meniscus repair?
Yes, that definitely. Because, I mean, if I'm addressing the meniscus root, and if there is something that is to be done with the articular cartilage, then I'd definitely combine the two.
yeah. Considering the question, I would like to share my experience. I have had some patients who have had both medial osteoarthritis and posterior root tear or the medial meniscus with a bit of, yeah. So there were scenarios where I have done a single stage high tibial osteotomy and root repair. And even some of the patients also needed ACL reconstruction in the same stage. And fortunately, touchwood, so far none of them landed up in stiffness. I have been sure start them on early range of motion immediately after the surgery, but they don't start weight bearing immediately after the surgery. I go well slow, like at 4 weeks, I start on partial weight bearing, at 6 weeks to full weight bearing. Definitely no full flexion of the knee until at least 3 months, even non-weight bearing full flexion. Like the weight bearing full flexion, as in squatting, happens at least after 6 months, and as much as possible, if possible, I tell them not to squat at all, because we never know how much the meniscus root is going to heal to the tunnel that we have created.
Yeah, absolutely right. I mean, look, Sasinder, there are different ways of skinning the cat. And there is no absolute right or wrong. And for a room of 100 orthopedic knee surgeons, there'll be probably 50 different ways of doing it. But as long as we get the basics right and we address the problems that there are there, that's all.
Exactly. Yep. And we are
I
still to
agree with
learn further
Dr.
as
Divya.
we do more procedures. We keep learning and we keep understanding it better. More than learning, we keep understanding the normal pathomechanics that's happening there.
You know what? I tell my registrars, my fellows, I have two knee fellows all the time. I tell them that the day I stop learning is the day I will stop working. That's
Yep.
and I mean it, and I mean it from my heart.
Yeah. Perfect, Dr. Divya Prakash. Thank you very much. Now, I would like to invite Dr. Soumya Agarwal. Dr. Soumya Agarwal is the lead of arthroscopy and sports injury at GMCH Udaipur. Dr. Soumya would like to present his experience on microfracture drilling for osteochondritis dissecans of the knee in a 26-year male. I'm sure there is something that everyone can learn from his experience. Over to Dr. Soumya.
Okay, so thank you so much for inviting me to share my case. I would like to share my screen first. Uh, so, is it visible, sir?
Yes,
Yeah,
Soumya, you are visible.
Dr. Swami Agarwal, it's
Okay.
visible. Yeah, just make
Yes,
it.
yes, sir. Okay. So I would like to start this case. So this patient came to me in the OPD. He's a 26-year-old male soccer player, and
Dr. Soumya, sorry
he
to
came.
interrupt you. Can you please put it
Yes, sir.
on slideshow?
Slideshow is put on, sir. Is it?
No, you have to go to the end. Yeah, yeah, yeah. Because it is come
But we are
down.
Now,
still
is it
not seeing the slideshow.
No, the whole thing is on.
now?
Can you do it again?
Is it a slideshow now, sir?
No, not it.
Not yet, not yet. We are seeing all your things.
Okay, no worries. You can go ahead.
Okay. So now, patient, he is a 26-year-old male soccer player, and he came with the complaints of pain at the right knee, while and he was also having complaint of pain in the knee joint in the right knee while he was sitting for a very long time, and he was also having difficulty in getting up after he was sitting for a long time. So, and he also complains of difficulty in running and playing his soccer game. And these complaints were since 6 months. So then he also gives a history of injury 1 year back while he was playing soccer. And on examination, the tenderness was present over the medial aspect of the right knee. And there was a medial joint line tenderness present, but the range of movement was full and it was mild terminally painful. And there was no distal neurovascular deficit. So, firstly, he has been given a conservative treatment and he has been given some NSIDs, but he didn't get relieved. So, the conservative management was failed. And then we asked, I would like to ask the panel, so what all investigations we need to get for this patient? Because this is a case for our junior faculties as well, or junior doctors as well. So, sir, I would like to ask the panel what all investigations you would like to ask for this patient.
Soumya, I mean, as an orthopedic surgeon, I think this was a traumatic event that the patient had. And you do the basic x-rays and then the MRI scan. I don't think we've got to get too worried about different kinds of investigations in this one. I mean, that's how I look at it.
Okay, sir. The X-ray was done at the time of injury, but it was normal. Right now, I don't have the X-ray, but I do have the MRI. When the patient came to me, the X-rays were normal, and then since he had failed conservative management, then the MRI was asked, and we don't have a facility of MRI cardiogram at our center. A normal 1.5 Tesla MRI was done. So this is the societal view of the MRI, and I would like to share this MRI. This is the
Please visible
societal
to
view.
us, Dr. Somme.
Yes, and this is the coronal view. In this coronal view, we can appreciate there is a osteochondral lesion in the medial femoral condyle, and also in this sagittal view, we can see that there is a small lesion on the uh, medial femoral condyle. And this is the axial view where also we can appreciate the lesion over the medial femoral condyle. So these are the MRIs of the patient. So, so
Dr. Dr. Somme, can we
yes,
stop it here
yes,
for a second? Yes. So, as far
yes,
as your history is concerned, the patient is young. You have a medial joint line tenderness, pain in sitting, squatting, and also during activities. So, medial joint line
yes,
tenderness is
yes,
suggestive that he might have a meniscus tear or a cartilage that is
yes,
there in the medial femoral condyle, medial tibial condyle, or there might be a ramp lesion. These are the things that we look for, and I think we should get an X-ray first, then an MRI.
yes,
And you said that you do not have a facility of a cardiogram. That is not always required in a patient with a cartilage lesion, and we can get a good cartilage scan with the 3 Tesla or 1.5 Tesla MRI as well. And if I see
yes,
this MRI scan, so we could see there is a subchondral bone edema in the medial femoral condyle.
yes, yes, sir.
Okay. So, and we can see some sort of changes in the cartilage, overlying cartilage as well. So, do you have the T2 weighted coronal section as well? We have seen the
Uh,
T1 weighted coronal section as, but is there a T2 weighted
So,
sagittal
right now
section?
these are the MRI images I have. I do have this one from PAX, but right now the video is not working, so I won't be able to move it. Yeah.
I think we've got
Okay,
enough
these
information with.
So, sir, for this lesion, I went in and we did a arthroscopy for this
so
patient. Yes.
so Dr. Soma, you have undergone the patient for
Hello.
surgery. Dr. Some.
Yes, sir. I actually I
Okay.
yes, sir. So I asked, yes, I convinced the patient that he is having an OCD or osteochondritis dissecans defect, which is visible on the MRI, and we prepared the patient for the surgical option, and then we went inside and I did the arthroscopy. So I would like to share the inside arthroscopy picture with you, and then I would like to ask the panel that what can be the options for this lesion. So this is the arthroscopy picture, which is uh, there, and then there's a flap over the medial femoral condyle, and there's a video I would like to play. If is this video visible?
Yes. Yes, we can see the video.
Okay, so this was a flap and this was the lesion. So lesion after I just cleared the flap. So approximately 2.5 into 2 centimeters was the lesion depth, and it was a grade 4 modified outbridge full thickness osteochondral defect of the medial femoral condyle, and it was grade 3C ICRS. Uh, So I would like to ask the panel, what would be the options for this type of lesion?
Dr. Samya, I think this is a very interesting patient. To start with, as Dr. Rajat had discussed, it will be great to see the X-ray and also the alignment of the limb, as in there a deformity. We can never know. We can always have some surprises. And in addition, the MRI is also possibly suggestive of a bit of avascular or ischemic changes that are happening in the medial femoral. If you're thinking about osteochondral lesion, it is more well defined part of the subchondral bone. Maybe there will be a bit of subchondral lesions, but it is quite well defined to the subchondral region. It does not involve or present as hypersensitivity or bone marrow lesion of the whole of the femoral condyle. So we have to make sure we are not missing on something. And when you see the arthroscopy picture, I mean, the lesion appears to be quite larger than it looks, as in there may be a bit of delamination of the more medial part of the cartilage, possibly covering the whole of the medial condyle of the femur. So the probe, the surgeon is the one who can identify it best, but there is a possibility that the whole of the cartilage has denuded or delaminated. And going forward, yes, the patient requires some kind of reconstruction of the cartilage, no doubts about it. It will depend on the size of the lesion. Do we have more idea on the whole size of the lesion? Could you probe the rest of the cartilage on the
Yes, sir.
medialmost part of the condyle? Do you think there is delamination of the cartilage from the subchondral bone? How do you think is the quality or the vascularity of the subchondral bone?
Sir, the subchondral bone was okay. The lesion was this much only. I just probed the lesion, but it was that lesion. Just I did the delamination.
Okay,
So,
there
Dr.
are.
Somme,
Yep.
so
Yes, sir.
any of the cartilage lesion we see, we need to differentiate between the pathology, etiology. So whether this is an traumatic event or whether this is due to some malalignment issues or whether it is due to the degeneration. So first thing is the alignment x-rays. So get the alignment x-rays done, whether this is due to some biomechanical issues. And then second
Sir,
thing is
the
the
alignment was. I had the
vascular
X-rays. The
insult
alignment
or
was.
the second thing is the vascular insult or what we call as an OCD. That we need to clarify. And also we need to differentiate between the condyle lesion and the osteochondral lesion. Here we see some bone marrow edema. That is not suggested that, it is there. It looks like a traumatic subchondral bone edema. It doesn't look like a OCD. So we can treat it as a cartilage lesion. Once you've decided that this is a cartilage lesion, that we can treat it, and this subchondral bone edema with subside with some non-wet bearing. So in that case, we need to look for the size of the lesion, also the location of the lesion, age of the patient. So this is a young patient, then we need to look for the size of the lesion. The size of the lesion appears, it is in the weight bearing zone and the size is too big. And the size has to be defined once you have debrided the defect. So every loose flex, every delamination, you need to remove it and then you define the size. And then according to the size, you need to have your options, and but you need to decide your options before the surgery.
Yes.
May I come in over here?
Yeah,
So,
please,
Yes, sir,
sir,
Dr.
please.
this
Divya.
was when.
Dr.
Dr.
Divya.
Divya, can you
So,
give your feedback?
Soumya, this is a very common case. Actually, it's something that happens quite frequently. And Rajat has very correctly
yes.
pointed out that this is not an OCD. I mean, you start off by saying that this is an OCD. This is not an OCD. Okay. There is a difference between OCD and pure chondral lesion. This appears to be a purely chondral lesion. Can you go back to the images, the coronal images, the T2 ones?
Yes, sir.
No, below that, the coronal ones.
Yes,
Yeah.
the coronal ones. Yes.
Now, there is absolutely no indication that apart from the bony edema, there is any actual structural damage to the underlying bone. So that excludes an OCD. OCD itself starts with O, which is osteo. There is no osteoedema is there, but not that, nothing else. Secondly, both Sasinder and Rajat, I mean, just looking at the limited information I have with the tibiofemoral angle, it actually doesn't look as if it's a malalignment issue. Okay, so that's my take.
Agree, sir.
We will have to take the full length views, but I mean, to me, it doesn't look as if it's particularly bad. Now, Samya, can you go back to the cartilage, the arthroscopy image, please? The one below that. Yeah. Now, both Sasinder and Rajat were absolutely right that this is not the full extent of the lesion. It is not.
Yes.
There is much
Mhm.
more damage, and the more you start to elevate with the probe, you'll find that it's bigger and bigger, and it is not going to attach. So the question you had in mind was, what do we do with this? For any
Yes.
lesion, how do we treat this? If it is purely chondral lesion, you can start off by talking about microfractures, which doesn't work in my hands. I've got very little faith in microfractures. If it was a small lesion, you could do an Oates procedure. You can do AMIC, you can do ACI or MACI or things like that. So it depends on what the facility is. I think I would not do microfractures. I would not do Oates procedure on this. I would go either for an ACI or I would go for an AMIC. Now, in UK, we are having some problems with the provision of the chondrocytes, so ACI is quite limited. AMIC is a very good procedure. I would suggest you go and do a mini open procedure. Don't try to be extra smart. Don't try to do it arthroscopically, make drill holes and layer on with collagen gel. Don't do it. My suggestion would be put the patient on the table, tourniquet up, make a mini incision, open up the joints, have a look, carefully elevate the cartilage that is surrounding the area of damage. Make sure that you get to the point which is firmly attached to the bone, and you cut away all the rubbish cartilage, because the one that is flapping about is actually going to damage the patient if you leave it over there. Once you've got it over there, you prepare the bone surface, you layer on the collagen, secure it, and then you treat it. And it'll have very good result. The patient is only 26-year-old, fairly good alignment. He should have very good results. Success rate is more than 90%. I would go for an AMIC.
Yep. I totally reflect on, agree to Dr. Divya Prakash's opinion. Just a addition, just to make it clear, yes, we have to expose the whole of the affected part of the cartilage. And remember, you cannot replace subchondral bone with cells, as in chondrocytes or as much as possible mesenchymal cells. If you feel you have to remove a bit of subchondral bone because it is not vascular or it is separate, please do a sandwich procedure, a bit of cancer bone impact over there, and then try to reconstruct the cartilage on top of it. And as has been reflected by Dr. Prakash, a smaller patient can do well with procedures like OATS, and larger lesions do better with cell-based reconstruction techniques. There is a window of flexibility. The results are relatively similar when you do a mesenchymal cell-based or bone marrow-based, adipose tissue-based, or collagen-based, in addition to stem cell. We have a bit of variability with equivalent results, but possibly the concept that we have to understand is small lesions, possibly osteochondral cylinder grafts, aka larger lesions, cell-based reconstruction technique. Yeah.
Okay, sir. Okay, so for this case, eventually we did a microfracture drilling with a microfracture hole. We had that, and the patient is 1 year post-operatively, and he is doing fine, and he is well into the game now. So these were the options actually. So I would have preferred oats, or as sir said, AMIC, but eventually we did a microfracture drilling, and the patient is doing well. So the things which I would like to emphasize right now is that how we decide to treat these sort of lesions is based on partial thickness or full thickness, and we have to identify the size of the lesion and the activity demands of the patient. And also the important things are that we have to see the body size of the patient as well, and the size of the lesion. So so I did microfracture healing, which stimulated the intrinsic healing potential, and the 2 holes were made with the help of a microfracture owl, and they were penetrated for the subchondral bone to produce bleeding, and then made the patient for 6 weeks non-weight bearing, and continuous passive motion was made, and patient is doing good. So that was the case actually done quite a time back. So so these were the results, sir. So I thought I would like to share this patient.
Yep. Dr. Samya, first of all, I
And
would appreciate you for sharing your experience and bringing it up for discussion. We, every one of us, I mean, have been in this situation at some point of a time, and we all have something to learn. I'll just add some more, I mean, of my experience to this case for the purpose of learning. Yes, you have done a good job in doing microfracture, but microfracture is known to give good results possibly until 2 years postoperatively. The fibrocartilage is likely to give a bit of pain relief, and the microfracture also possibly create a bit of healing potential for the hyperintensity, whatever pathology that is happening underneath, possibly that healed down, so the inflammation came down, and you removed a bit of the foreign body or whatever was there inside the joint, so that will also reduce the inflammation. So all these are likely to improve the general condition of the patient. But what microfracture allows is healing by fibrocartilage, not hyaline-like cartilage. We have never been, at least so
Yes.
far, been able to replace with hyaline cartilage. We would like to boast by saying it is hyaline-like cartilage, but it is definitely better than fibrocartilage. Hyaline cartilage has far different biomechanical properties in comparison to fibrocartilage. Fibrocartilage is just nothing but fibrous tissue. Hyaline cartilage can take load, can weight bear. So the general information that we have, the general evidence that we have is microfracture can lead to better results for up to 2 years of age. And the the accepted indications for microfracture is a small lesion and a shouldered lesion. That means it can fill up with fibrocartilage, and the shoulder of the lesion will offload the fibrocartilage from weight bearing, so the patient will be relatively pain free. And even then, the total cartilage volume is known to reduce over years. That is because the point loading or the load per unit area is still higher even after microfracture in that part of the joint, and hence the cartilage volume is expected to reduce. This is just a precursor for osteoarthritis. This is all what we know, but I can't say this patient will go on to osteoarthritis, this patient will go on to cartilage volume reduction, or microfracture is not the right treatment for this patient. None of this can be said. This may be the, this is the evidence that we have for the younger generation to learn and take it forward. Dr. Divya Prakash, you have something to share?
No, I completely agree with you, Sasinder. microfractures were started by Dick Stedman, and the results that he gets, nobody else in the world gets. And you wonder whether it is because of his either techniques, superior techniques, or patient selection of the publication, or what else, we don't know. I personally do not think I can get the results anywhere close to him. But the other thing that you've pointed out very correctly is that it has got to be a lesion less than 2 square centimeter. And this lesion that Soumya was showing was definitely more than that. The good effect of the microfracture doesn't last for more than 5 years. And that's a well-established fact with lots of publications from across the world. And the worst part is that because when you're doing a microfracture, you're compacting the subchondral bone, it actually stops you doing, or not stops you, it reduces the efficacy of any subsequent procedures that you might do. So for example, if in 5 years time you say that the patient has got problems again, and you want to do an AMIC or ACI, the result will be poorer because you have already done microfractures and you've damaged the bone over there. So I've got very strong resistance to doing microfractures unless I feel that it has got all the right indications.
Totally agree with Dr. Divya Prakash. I have stopped doing microfracture. What I do, I like to label nanofracture, but it is not nanofracture. Conceptually, what we would like to do is drilling into the lesion, not microfracturing it. And well, I won't drill with a K wire because again, K wire you are compacting the cancellous bone into the canal, and that is not going to allow so much of mesenchymal cells to flow in. As possible, use the micro drill bit, the flexible guide to drill in and remove whatever bone you are drilling, so that you're not compacting it and allowing the mesenchymal cells to flow in. Also, micro drilling or microfracture or nanofracture, all for specific indications. In my practice, indications are coming down a lot. I wouldn't follow. In my practice personally, I wouldn't follow the classically described sizes as the indications for microfracture because the demands keep growing, and we can't say a 1 centimeter lesion is not so important even if it is told out, depending on various other factors. For example, the age of the patient, the physical demands of the patient, and the possibility of conversion to osteoarthritis. Dr. Rajat, you
Dr.
have.
Sashi, Dr. Sashi, yes, Dr. Sashi. Excellent case presentation, Dr. Soumya. Only thing which I kept open for discussion during my opinion is regarding the size. So, Indian Cartilage Society with our founder, Dr. Deepak Goyal, did a consensus meeting in 2015. And regarding the evidence which is available, it was available at that point of time. The papers which were considered were before 2015. So regarding the size of the lesion less than a centimeter square, microfracture does well with an instability like a ACL less than 1 centimeter square size lesion. It does well, but the results with all these marrow stimulation technique, they deteriorate after 2 years. So if the size of the lesion is more than 2 to 3 centimeters square, the OCT, osteochondral cylinder transfer, they do well. If the size is still more than 3 centimeters square, so in those cases, the ACI or the other cell-based therapies or the matrix-based therapy, they does well. And we are planning to get the current consensus this year in 2025. After 10 years, we are planning to get the recent literature, recent evidences regarding the size, age, other factors. So I think as far as the current evidence with the Indian Cartilage Society, the current recommendation is less than a centimeter square lesion microfracture, 2 to 3 centimeters square OCT, or more than that is ACI. But we'll get the recent evidence, recent consensus to 2025.
Yep.
Sir,
Perfect, Dr. Rajat.
many a times when we do arthroscopy and we are going for either ACL or meniscus, then we sometimes we find it's an incidental finding that the cartilage is sometimes it's not there, and it's a very small lesion, less than 1 centimeter. So that time we can go for microfracture drilling if the
Yep.
panel agrees.
Yep.
So,
Yep.
Dr. Somme, these patients do really well. The instability is ACL patients. If you do a microfracture, smaller size of lesion, a centimeter square or 1.5 centimeter square, these patients do well in my practice.
Yep.
Yes, sir.
I agree. Less than 1 centimeter, definitely a good indication. So we have one last question. Dr. Nishit Shah wants to ask, why not mosaic plasty? Dr. Divya Prakash, why you can do mosaic plasty for this patient? Why you should not do mosaic plasty for this patient?
Yeah, I mean, it's a very good question, and we didn't talk about mosaic plasty. I mean, oats is a kind of a mosaic plasty. So I'm not talking, when I say oats, it's not just one cylinder. I can put in as many cylinders as you want. But the donor site is limited. The amount of plugs that you put in is going to be limited. I personally feel that if it was exactly the size that we can see in the arthroscopy picture, and if it was no more than that, then definitely oats or mosaic plasty to be considered. But I've got a very strong feeling. Sorry, there's some disturbance somewhere. Um,
Yep, it's gone now. It's gone now.
Um, I personally very strongly feel that the cartilage that we saw, it was undermined and it was unstable. And if you start to remove the unstable cartilage, it would become a much bigger lesion than what we could see on arthroscopy. And I think it was far too big to do a mosaic plaster and oats procedure. By the way, guys, where do you take your plugs from for the oats?
You mean for mosaic plasty for this patient?
Yeah, where would
Yes,
you?
Dr. Rajat. I would shoot the
So,
difficult question to the others, not to myself.
for the middle femoral condyle, this has to be a little femoral condyle, and from the non-weight-bearing portion, uh, at the anterior edge, anterolateral corner of the femur.
Yeah, perfect. I do agree. I mean, in my opinion, for this patient, given the options, yes, I may do mastectomy. Uh, um, Many years past in my practice, there's a bit of noise on your side. Dr. Rajat, can you mute? Yep, thank you. So, yes, I have done mosaic-plasty for such kind of patients, but nowadays, provided the opportunity for cell-based reconstruction and the possibilities like collagen patches, and I mean, a better understanding of the bone and the subchondral or the cartilage subchondral unit, with the possibility of doing an impaction subchondral cancel bone grafting and reconstructing the surface on top of it. We have, in my experience, possibly better opportunities, better options than mosaic plastic.
No, that's absolutely fine. The reason why I was asking you the question was because in whatever limited and specific cases where you've got mosaic plasty indicated, try something different. You know, when you are looking at the femoral condyle of distal end of the femur with an arthroscope, you know, that is the notch, that is the ACL attached like that. Try taking plugs from there. Try taking plugs from there. The patella does not come into contact. Okay. The capsule of the joint will not rub against it. It is very safe. I've been
Agreed,
doing
agreed.
so many years. That is a great place and it's easy to access. You don't have to open up the knee joint anymore. You know, knee open is fine. So try
Agreed.
that.
So, Dr.
But how many
Divya,
cylinders
Dr.
and of
Divya,
what should be able
just
to
just to
move?
intervene. Yes, Dr. Divya, that tends to for the smaller sizes of the plug. If you take a plug of 6 millimeter, that's fine. So if you are taking a plug of 8 to 10 millimeters, I think it's better to take from the
No, you
the
can do,
anterolateral corner.
but try it. Try it. I take 10 millimeter plugs. That's not a problem because I swap From the donor side, I take the plug and put it into the recipient side, and from the recipient into the donor side. So I fill it up anyway. And the patients do very well. There is no donor site morbidity. Try that.
Yeah, that is an interesting source, and I totally agree that except in the terminal final hyperflexion in a very lean patient, the patella is not going to come and get
No,
in contact there.
even
Yes,
in full flexion, the patella doesn't come into contact. Have a look. Next time you do that,
yep,
even if you're not taking a plug of bone and cartilage, just check where the articulation of the patella is. You'll find that it will not come in contact with that.
agree. Okay, Dr. Rajat, do you have anything more?
I think we have done an excellent discussion about the root tears, also an excellent case presentation by Dr. Some. And I think this is going to be a good message to all the cartilage scientists, cartilage surgeons, the arthroscopy surgeons regarding the root tears and the cartilage lesions.
Thank you so much, Dr. Divya. Thank you, Dr. Rajat and Dr. Samya, for spending your valuable time with us. And we encourage more and more young orthopedic surgeons to present your cases here just for the sake of learning, everyone. And see you back and around in another presentation.
Thank you very much.
Thank you so much.
Thank you. Thank you, Dr. Divya.
Thank you. Bye-bye.
Thank you, Some.
Thank you, sir.